In February 2022, TTAC, in partnership with the National Consortium of Telehealth Resource Centers, hosted a national virtual technology showcase. In this 2 day event, we had a variety of speakers, topics, and presentations. The following is a recording of our keynote speaker, Dr. Rhew's session featuring major trends and opportunities in digital health. We are pleased to make this recording available for your viewing.
Great pleasure to introduce to you our keynote for today, Dr. David Rhew. Dr. Rhew is a global Chief Medical Officer and VP of Healthcare for Microsoft. He is an adjunct professor at Stanford University. He holds 6 U.S. technology patents that enable authoring, mapping, and integration of clinical decision support into electronic health records. And he's been recognized as one of 50 most influential clinical executives by Modern Healthcare. Dr. Rhew received his Bachelor's of Science degree in Computer Science and Cellular Molecular Biology from the University of Michigan. He received his MD degree from Northwestern University and completed his internal medicine residency at Cedars-Sinai Medical Center. He has served as the Chief Medical Officer and VP for Samsung. He's a Senior Vice President and CMO at Zincs Health Incorporated, a clinical researcher at the VA Greater Los Angeles Health System in Rand, and an Associate Clinical Professor of Medicine at UCLA. Dr. Rhew has served on the National Quality Forum's Executive Committee for Consistent Standards and Approval. He chaired the Consumer Technology Association Healthcare Technology Board, and he sits on the Governance Committee for NEST, the National Evaluation System for Health Technology Coordinating Center, the Medical Device Advisory Group for FDA, CMS, and NIH. I first met Dr. Rhew when he talked to us at our Crystal Ball project, and we were just so intrigued with him. He has such wonderful sharing advice for us that we were honored that he agreed to present to us today. So Dr. Rhew, thank you so much, and I will turn it over to you.
Oh, thank you so much. And it's a real pleasure to be here as well. About 20 years ago, I was working on research that related to how technology could be used to provide information, the right information at the right time for clinicians. And I remember at the time, we had a meeting coming up with the late CEO of Cerner, Neil Patterson. And this was right around the time of, again, just Chinese New Year, which we just passed. And I remember thinking to myself, how can decision support be applied in the setting of an electronic health record? And in the opportunity that arose by waiting for our seats, I grabbed the flyer, a Chinese New Year flyer, and they scribbled on the back of it the foundation or the prototype of what an evidence-based order set could look like in an electronic health record and how one could manage the content and ultimately integrate that. That was something that at the time I thought was an extraordinarily interesting innovation, one that could improve quality of care. But what really took off was the fact that in parallel to this, or actually a few years later, the American Recovery and Reinvestment Act initiated the HITECH Act, which required all hospitals and clinics and healthcare providers to be using electronic health records. And it completely transformed this idea to a product, to something that ultimately became a major trend and a major opportunity for clinicians to standardize. And so what I'd like to talk to you about are what are some of those new trends, those opportunities that we see in the area of digital health that's going to transform the industry, that's going to transform the way that clinicians and patients interact with the health system. And so what I'd like to do is I'd like to actually touch on 3 of those trends. The first is around health equity. We oftentimes recognize that there are disparities of care, and I've seen this both in my research as well as in my clinical practice between individuals that have less resources, that are in underserved areas, and that oftentimes are at the highest risk for worsened health outcomes, but oftentimes do not have the opportunities to be able to take full advantage of the resources. Consumerism, another a big area that we also have recognized about the experiences that individuals have in the health system, making it much more easier, more consumer friendly, but also providing transparency and visibility into the processes to become better informed. A lot of exciting advancements that are happening in this space. And then the third is around virtual care. We've seen a dramatic increase in virtual care, specifically telehealth visits during the pandemic. It subsided a little bit, but what we're also recognizing is this has opened the door for us to start thinking about what's next in terms of virtual care. So those are the three topics I'd like to touch on today: health equity, consumerism, and virtual care, and then finding ways that artificial intelligence and machine learning can be applied on top of these. So let's talk about health equity. If you look at how healthcare is delivered today across the globe, it's predominantly based on individuals recognizing that they need assistance, seeking that help from a clinic or a hospital, and then receiving care, whether it's a consultative care or a procedure or a surgery. Then there's a series of follow ups that are recommended, and it's recommended that people try to stay healthy with some recommended either activities for diet or physical exercise and medication adherence. That works for some people, but unfortunately for many individuals, that's not good enough. That's not sufficient. Access to care is one element, but the environment that people live in, this has become one of the most significant factors in terms of improving health outcomes, one's environment. We sometimes refer to them as social determinants or social influencers of health. So for instance, your neighborhood could actually in many cases be the primary determinant of your health outcomes. Sometimes they call it your zip code. That is because of all the factors that have been kind of married into that one number, your zip code, your socioeconomic status, all the people around you, access to food, other types of things that relate to the ability to have affordable housing. This is something that we've recognized as a critical part, your environment. But also the challenges that people have. Sometimes they can be complicating. The mental health challenges, the substance abuse that's oftentimes laid on top of this, those make it very difficult for people to take proactive intervention. And so in this case, the model of care is very different. It really is about individuals receiving care where they're at by a team that is oftentimes not a physician or a nurse, but individuals that are addressing the needs that we see that come up every day as barriers, and ways that we can improve upon them will lead to better health outcomes. We recognize this as we were working with communities across the globe, but in particular during the pandemic, when we started trying to deploy vaccination clinics, and these were everything from mass vaccination clinics to pop-up clinics, leveraging a technology that allowed us to be able to go beyond the traditional means of electronic health records. And in that uh, discussion that we had with many communities, where we were looking to find ways to make it easier for the individuals to receive those vaccines, we saw that there was something that was missing. And that missing piece was trust. It was about a conversation that was needing to be had between individuals in the community that had a mistrust or a distrust with the health system, with the public health, with science in general, and individuals in the community that could broker that conversation with the right information to be able to provide information that would be comforting and allow them to be able to bridge that gap. Now, that was something that when we empowered those individuals, and these are oftentimes folks such as pastors or other members of the religious communities, individuals that work in services such as barbers and beauticians, folks that work in the schools that have long-standing relationships with the children and the families that they service. Those were the folks who we empowered with the information, and they ended up becoming the primary advocates of the vaccine, as well as the need to bring them into some of these events that we were then hosting in the communities. And in those events, we realized there was a huge opportunity not just to provide COVID vaccinations, but also a series of other tests. These are things like COVID tests, but screenings for blood pressure and diabetes, cancer screenings, and of course the immunizations beyond COVID, such as childhood immunizations for to get to school and adult immunizations, connecting them to social determinants of health programs for transportation, food, income, and then also connecting them to a healthcare provider, the local healthcare provider, so they could receive those follow-ups. This was a comprehensive approach, and it worked very well. It worked in underserved populations in the Latinx community, where we started exploring first in Washington and then in California with a large number of migrant workers, and then in Georgia with in Clarkston, which is one of the most diverse areas in the country. And what we found was technology was required in the back end to support this because with every interaction, with every immunization, it required us to be able to send that information to either through an electronic health record to, so that follow-ups could be provided, or to the state immunization registry so that a documentation of the vaccination could be provided. It needed to be secure. It needed to be something that we could automate and enable people to be able to gain access to that information on their smartphone as in the form of a QR code that they could then use to be able to access the records later on. This was something that we realized was a public-private partnership that needed to be supported through technology, but being led by communities. A great example of how technology supporting the systems, allowing them to be able to provide better care. Now, one of the things that I just talked about there was consumers being able to gain access to their information. And that was something that has been going on for quite some time. People using and leveraging tools that we see today that are oftentimes used on our day to day, a smartphone, a smartwatch, anything that allows us to be able to have that direct communication with our body. So, patches and other wearables. And that has been for a large part of, or for a significant time, an opportunity for consumers to be able to tap into things that they hadn't been able to look at, their heart rate, and being able to look at other types of metrics that relate to activity and sleep and even stress. And this has empowered them to be able to have the right information that they can act upon. Now, the challenge is that a lot of times we need to go beyond those metrics and we need to start thinking about how to make it easier and more relevant for individuals. This then gets us to the point of thinking about all the information that consumers need to have relative to better health. And it's not just about the biometrics, but it's about your health record. So, how do you actually access your health record? Well, if you've ever tried to go through your healthcare provider, it can be a challenge. Sometimes you don't get the complete record, and it certainly can take a while for it. It may not be in a digital format that's then shareable with other healthcare providers so they can use that. What we've seen now is a big movement, starting with the 21st Century Cures Act, leading to the CMS interoperability rules, and now the implementation of FHIR standards and open APIs, whereby consumers can gain access to their medical records by requesting that. And the exciting thing is that healthcare providers, the payers, the electronic health records need to comply with these standards to enable consumers to be able to gain real-time access in an electronic and or paper form. This is something that now can be done through FHIR or fast healthcare interoperability resources. With respect to the things that we had been seeing during the pandemic, consumers can also gain access to their medical records, vaccine records, test results, also through FHIR, this time smart on FHIR applications using smart health cards. We're starting to see a big trend towards that. And as more consumers gain access to their medical records, they'll be empowered with the right information to be able to make the right decisions and be able to share that with healthcare providers and other folks who need to help support them. Which gets us to the issue that when you interact with a healthcare provider, it's not sufficient to rely on those periodic clinic visits. What we have to do is we have to see if there's multiple touch points throughout a person's care journey to enable support for them to provide the right information at the right time. And it doesn't have to be a physical visit or even a virtual visit. It needs to be an opportunity where they can access information that's relevant to them. One of the exciting opportunities that we've seen is that when we can start thinking about use of different types of technologies, you can pull that information, allow us to be able to analyze it, and then push it back out to the individuals in formats that they can use. This ends up becoming a process where data can be more effectively managed and you can get that right information at the right time. What you're seeing in front of you is an example of how this data can be managed and some of the extraordinary use cases that can spring from when data is ingested on the upper left-hand side to where it's analyzed using operational analytics and clinical analytics and AI tools such as natural language processing, and then pushed to individuals and or the care team through tools that allow them to be able to provide virtual visits and or care coordination. This is a process that we have seen again and again work when you take these disparate sources of data, and I've listed several of them: electronic health records, imaging data, genomics data, third-party data like social determinants of health, Internet of Medical Things. So these are your wearables and all the other types of things, or perhaps even implantables. All that information being ingested, analyzed, and then being able to push out to a variety of different tools that people can use every day. This is an example of how this type of technology can be deployed and made real time for consumers. During the pandemic, many individuals had questions about whether or not they had COVID. They wanted to know, should I go get tested? Should I go into the hospital? A lot of the confusion was creating uh, a, a need for consumers to be able to see a healthcare provider immediately to get that answer. And then they were flooding waiting rooms and ERs when in many cases they weren't sick, and they were exposing or being exposed to those who were sick. So what we realized was that the chatbot early on could be customized to provide individualized recommendations around whether or not they should be staying at home or perhaps coming in for help, or perhaps getting help virtually and connecting them digitally to a virtual care visit. Chatbots have now since then been used for clinical trials matching, allowing us to be able to think about other ways that the right information can be provided to individuals. We can take that same type of technology, that clinical decision support tool, and bring it into platforms that help support, I'll call it the extended care team. These are everyone from a social worker, a case manager, to perhaps even a receptionist or a call center agent. So let's imagine I'm making a phone call to schedule an appointment, and I've basically asked for a certain set of dates. They've scheduled me, and I'm done. Well, that actually was a missed opportunity for the call center agent. Because imagine if when I had called, there was an API call directly to the medical record. It identified that I had missed my last 4 appointments. I'm at a high risk for missing or at least being late for this next one. The very next question shouldn't be, what's the next available appointment? Let's schedule it. Should be, hey, I've noticed you missed your last 4 appointments. Did you know that we have a series of resources that can be provided? Vouchers, we can have rides pick you up. We can have text messages provided to you. Oh, you've never done this before? Did you know that we could also perhaps support you in this process and have someone contact you on this? Looks like your visit is also something that could be eligible for a virtual care. You've never done that before? We can set that up right now. What we're now talking about is finding ways that we can bring these conversations earlier into the process and support the extended care providers with the right information at the right time, this time using chatbot technology. So we're now starting to get into this concept of merging AI, which is a chatbot functionality, with virtual care visits. And that is now one of the most exciting things that we're seeing in how care can be delivered. A lot of times we think of virtual care as being the telehealth visit or the remote patient monitoring, but we're now starting to see patient data surfacing up in these visits so that we can pull directly from the medical record. We can see the trends and the graphs, so that allows us to be able to better understand. But we also have the ability to take some of that data that we now have access to through FHIR APIs and other mechanisms, analyze that, and then present it back. And a large part of that is around analyzing unstructured data. Unstructured data could be everything from a clinical progress note to a conversation. I'd like to give you a few examples of like how natural language processing can then be applied in this clinical encounter. So the first will be around something called ambient clinical intelligence, a conversation that a patient has with a clinician. And as part of that conversation, that information being converted into something that can be integrated directly into the medical note, saving the clinician time for entering into the EHR, and also improving the clinical user experience for the patient. Let me show you a video that describes a little bit more about this.
You don't become a doctor to bill. You become a doctor to take care of patients. You become a doctor to serve humanity. Ambient intelligence allows for the patient and doctor to be a patient and a doctor, like it used to be.
There's a certain business requirement for a structured note and careful documentation, precise diagnoses, and carefully backed up coding for the business practice of medicine. But ultimately, it's about the patient's story.
If you look at the promise of meaningful use and all the reasons we got into a digital health record, it really was to take better care of the patient. Unfortunately, sometimes we've done that through a barrier, meaning we added a keyboard, we added a computer. I think that's a key part of why physicians are frustrated.
And I mean, you notice as a patient, you notice that your physician is typing and talking and, yeah, okay, yeah.
Now we can go into the background and just capture all the information you needed, but also maybe more importantly, capture something that was missed. That missed was the patient's story.
There's a device on the wall and it's listening to your conversation and it's able to discriminate between a patient and a physician and a family member and is able to generate a progress note and a patient encounter based on your conversation.
What it has enabled is that I can pay attention to what you are saying, because it is very important for me to have the empathy and you to feel as a patient that you are telling somebody who actually cares about you.
Hey, Dragon, start my standard order set for arthritis pain.
The idea of a computer that can listen like in Star Trek and just hear what's going on and make sense of it and slip into the background and listen, but only interject when necessary, that was for a long time a fantasy.
I would say before, in a typical week, I would probably spend 6 to 8 hours documenting, just simply dictating and signing notes. I bet that my time has been cut into half, if not thirds, because of nuance now.
It takes the hands-on time that the provider has to spend with the computer and puts that time back with the patient.
It really takes a lot of that manual work out of the patient encounter and just allows it to happen kind of naturally.
Ambient puts a listening device in the room quietly, securely, privately, and allows the two people in the room to really have a very intimate discussion on very private things. Knowing that the necessary recording of that for the business of medicine and healthcare can go on in the background, but letting that personal connection continue. And that's the reason I think almost all of us went into healthcare. It's to be able to be there for people, to express caring, to express empathy, and to connect as human beings.
So in that example, what was happening was that entire conversation between a clinician and a patient was being captured from voice to text. It was actually being identified in terms of who was speaking, but then the natural language processing, or the AI, was being applied on top of that text so that we could understand what was actually being said. It was codifying in the back end to terminologies such as SNOMED and ICD-10. And then from there, it could then get organized into a clinical progress note, which could then get reviewed by the clinician to make final edits and then pushed directly into the medical record, saving the clinician time, but also improving the experience for both the patient as well as the clinician. This is something that can also be done, not just in the in-person setting, which you saw there, but also on virtual visits, saving the clinician time as they do virtual visits. So extraordinary opportunity. Another example I wanted to highlight relates to the use of text. In this case, allowing us to understand how information that is in unstructured formats can be analyzed so that it can be presented back to clinicians so that they can make the right decisions at the right time. This is an example of a virtual tumor board where clinicians are all gathering to discuss the care of patients for the cancer and trying to make the right decision for that patient.
We're all touched by cancer in one way or another. Every cancer is different. Tumors can have hundreds and thousands of cell mutations. How do we find that one change that we can target and treat that cancer?
There's millions of scientific articles covering specific mutations and combinations with drugs.
We can't possibly keep up with all that literature.
The clinical knowledge base is an innovative technology where all those variants, mutations that exist in cancer are being curated as they're discovered by researchers around the world.
That's where our collaboration comes in with Microsoft AI to help us triage the literature. Machine-assisted human curation can assist going through all of those publications and saying, this is one, so that the team can use their scientific expertise to interpret them.
It's a life or death situation. It's also a question of how you accelerate certain discoveries and bring them into clinical practice. We have a stage 4 esophageal cancer patient who's 60 years old.
We can more accurately predict patient responses to a combination of targeted therapies, immunotherapies, and even drug resistance. It is that funnel to be able to get to the right mutation with the right treatments associated.
With Microsoft AI, oncologists will be able to improve patient outcomes.
Every morning I wake up to fight cancer. Through the collaboration with the Jackson Laboratory and Microsoft AI, we can know that we haven't missed anything. And it's just been wonderful.
Yep. So just a quick recap, these are natural language processing. This one was text. The other one was voice. Now, I'd like to actually now share with you an opportunity to be able to apply artificial intelligence also in a virtual care setting, but in 3 different contexts that are so extraordinary. They are things that today it's hard to imagine that we could be doing this. It seems a bit like science fiction to be able to then create 3D holographic images and allow for patients to be able to interact with it and see exactly what needs to be done, as well as surgeons, to be able to then bring in a whole team of individuals and have remote consultations virtually, but also real time. And then the third piece is around allowing us to be able to create a better experience for training and education for the junior faculty and for the other individuals across the globe. I'd like to give you examples of each of these to give you an idea of how this is being used and can be used across the country and the globe. So let's talk about the first one. First one is around patient consultation. And I'd like to show you a video that was done with one of our partners, Apocular, where they have been looking at how this type of technology using the HoloLens as a headset, but also on the back end, leveraging the Microsoft Mesh powered by Azure for the AI to generate new images that allow individuals, patients, as well as providers to be able to take advantage of the information in 3 dimensions. So let's take a quick look at this video here.
Medicine is in the midst of digital change. Mixed reality and artificial intelligence are already improving patient care today. Virtual Surgery Intelligence, or VSI, is doing just that. With this software solution, MRI, CT, and other medical scans are displayed in 3D in Microsoft HoloLens 2 mixed reality glasses. This gives the patient a deeper understanding of the results, surgical procedures, and treatment methods. Before surgery, the doctor uploads the CT and MRI data onto HoloLens 2. The VSI recognizes the patient through anatomical landmarks and positions the stored image on the surgical site with millimeter precision. During the after-surgery round, the patient's data is quickly retrieved and displayed using VSI and HoloLens 2. At a glance and without a computer, the doctor can concentrate fully on the patient, answer questions, and discuss follow-up medical care. Being able to easily dictate a report, take photos, and retrieve archived images saves valuable time, facilitates everyday life in the hospital, and provides quality assurance. That will also make other processes in the hospital more efficient. VSI and Microsoft HoloLens 2 define a new medical standard.
So just a quick recap, what was happening was the images, the CT, MRI images are being uploaded and then recreated in 3 dimensions that allow for the surgeon to better understand the landmarks in ways that can help guide them before the surgery. And then afterwards, they can do a post analysis of that and look for the delta or the comparison. It can be also used for patient education related to the specific type of surgery. What we also have seen is that the opportunity to go beyond a virtual care visit of just simply having people on a video screen to now having them see the exact same things that you're seeing from the point of view that you have as a clinician. And it may be within a clinical setting or may even be outside of a clinical setting. I'd like to share with you an example of some of the great and really groundbreaking work that's being done in this space, leveraging the Microsoft HoloLens 2, but on the back end, the Azure piece for the AI with the Microsoft Dynamics 365 Remote Assist. And this is work that's being done by the National Health Services, or NHS, Imperial College. So let's jump right and show this video.
The concern was that we were going to have mass casualties with thousands of people dying and that the hospital was going to be overrun. And it was immediately obvious that we were not protected, we didn't have enough PPE. And so there was a lot of fear that actually we were all going to get really sick. And then in the second week of March, that's exactly what happened. You know, we lost a third of our team in a week. I was sat there at the beginning of the COVID pandemic and I counted 29 people in a close proximity in a single trauma call. And I was thinking, well, if this is how we're going to run the next few weeks, a lot of people are going to get sick and we have to change this really dramatically. The simple concept was, look, we're going to create completely virtual ward rounds. Rather than sending 4 people, we're going to send 1 doctor in. We very quickly started working with the headsets to identify some use cases. So when you place the headset on your head, what the user will see is a virtual screen or a mixed reality screen, which they can position into any real space in the room that they're standing in. And on that screen at the moment will be the face of one of their colleagues who will be interacting with that user through a webcam based on a desktop. We can call other experts that we might want to call into that clinical scenario. And we can also pull up images and content. So we can look at electronic healthcare record data or x-rays or images. And what it means is that you have all the information, all the specialist care that you need at the patient's bedside, there and then. And it's all in one headset. When this crisis hit, it became apparent that the NHS had to work in a different way, and through really high-level strategic kind of digital infrastructure projects, Teams was just nationally adopted by the NHS. Teams really is now, I would say, an essential tool. We could not run our organisation pretty much without it. The fact that their staff are safe, their ward rounds are really efficient, and that they can communicate more effectively with their staff. COVID-19 will change everything forever in terms of the way we work and how we work. In terms of mixed reality, HoloLens 2 really is the only viable product that we have in the space. And I can see a point where these sorts of tools will be the norm, where you will go on a ward round, or you will go into a clinic, or you will go into an environment that might be high risk, that might be challenging, or where you might need specific capabilities of these sorts of technologies, and it will be there, and you'll just use it, and it won't be a novelty. What I'm absolutely convinced of is that we are just at the very beginning of a very long and exciting journey. And I think what's been very important about COVID is actually it's just given us a real shot in the arm and a huge step change in our perception of these technologies and what value they might bring. The concern was that we were going to have
So extraordinary work the NHS is doing, groundbreaking in the sense that they are now starting to look at ways that we can expand our capabilities for virtual care. And I'm also imagining how this could be used in third world countries to help support individuals that have less training in certain procedures. This gets us to the whole issue of training and education. Today, we're in sort of this model that is more antiquated than one would like. The see one, do one, teach one model. It doesn't allow us to be able to scale and provide individuals with the capabilities to learn remotely and with a high level of efficacy. I'm going to share with you some results that we've seen relative to the work that's being done at Case Western Reserve for anatomy, and this is just one of many different types of areas where they have found that the students that use these type of technologies had 50% higher retention rates with 40% less class time. I mean, I would love to have had this when I was a student, just allowing us to be able to become much more efficient with our time, but also much more effective. And then what we're now starting to see is this all coming together with Microsoft Mesh, which is powered by Azure, allows us to be able to put this on an AI platform, pull into the different mechanisms. You can have create avatars. You're seeing a video right now of avatars that are individuals real time, someplace around the world, interacting real time with the information that's in front of them. This is an extraordinary means for us to improve and transform the way that we collaborate. On the topic of virtual care, we can't leave without talking about remote patient monitoring. Remote patient monitoring, many different sensors and wearables and patches and in ways that we can track information. Today, a lot of that information is oftentimes tracked individually with each one of those metrics having upper and lower bounds, alerts being applied to them. You can have elegant dashboarding. But what we need to do is we need to synthesize all that information and boil it down to one number, that's an index of whether or not the person's getting better or worse. This is a screenshot from one of my favorite movies, Moneyball, in which what they were trying to do is trying to figure out how to put the best baseball team on the field based on a variety of different metrics for hitting and on-base percentage and situations. What we also need to do is apply the same type of approach to healthcare. We have actually been doing this, though. This is not new. This is something that we've been doing in the form of clinical studies. I'm an infectious disease doc. I spend a lot of my time in the area of community-acquired pneumonia. In pneumonia, we know that patients that have a higher age, that have certain comorbidities, that have certain biometrics, are at high risk for 30-day mortality. In fact, we can create an index, a scoring system, which you see in front of you. Turns out that age is the most important variable. This was validated in multiple different large cohorts over a long period of time. And by the time it actually finally got implemented, this is something that we have now seen new and more advanced ways for us to do this. But the reality is we can do this real time with artificial intelligence. This gives us an opportunity, to be able to start thinking about how can you start looking at larger populations and individuals, each having their own set of characteristics, looking at ways that we can create a metric that says, of all patients like me, perhaps of a certain gender, certain age, certain set of comorbidities, certain set of prior histories. I want to know, in this cohort, am I getting better, worse, or about the same? And then in which case that can lead to early intervention and hopefully lead to better outcomes. What I've talked about are three major trends: health equity, consumerism, virtual care combined with artificial intelligence. In each of them, technology has played a critical role. Technology supporting the health equity initiatives through the Vaccine Equity Initiative, which I just talked about earlier as the public-private partnership model. Consumerism, starting to think about how we empower consumers with their health, but also empower the extended care providers with decision support. And then thinking about ways that we can apply AI and ML in virtual care settings by using natural language processing, whether it be voice or text or mixed reality, or perhaps now applying the predictive analytics on remote patient monitoring to look at populations and becoming much more precise. This is the opportunity for us to be able to take these technologies, ride these trends, and transform healthcare. Thank you very much.
Thank you, Dr. Rhew. Wow, that was fascinating. We do have several questions in the question box. We've got about 15 minutes, so I will go ahead and ask the first one. When a device is listening to the exchange between the doctor and the patient, is the patient told of the recording? And if so, does that ever chill the candor of the conversation? And then how are the recordings maintained after they're created?
Great question. Whenever we apply technologies, it's very important that we bring the patient in the loop so that they understand how these technologies are being used, who has access to the data, and ultimately giving them a voice in whether or not this should be applied. This is part of a normal conversation. I didn't show it in the videos, but every one of them is going to be about, we've got a technology here. This is going to help both you and I as we start to move towards a better opportunity to apply this information so I don't miss anything, that I'm able to make sure that it's well documented, that it speeds things up. This is something that is beneficial for all parties, but it has to be communicated by the individuals that they trust to ensure that they understand how this will be used, not just for voice, but really for every type of data that is being captured, whether it's a wearable. Important to recognize that information. Where's it going? How's it going to be managed? Who's going to have viewing of that? That type of information and conversation has to be had with patients and consumers to empower them with the decision to say, hey, I feel good about that, or I've got questions or concerns. So totally supportive of that.
Okay, thank you. The next question we have then is, knowing that federal and state legislation surrounding telehealth is largely uncertain, how would you suggest health systems mitigate utilizing these great opportunities to address SDOH while not knowing the future state of virtual care?
I love this question also because right now, one of the biggest variables that will impact one's outcome is your zip code. And that means social determinants of health, all the factors that we know have to be addressed. If our goal is to improve patient health and we ignore this, we're like we're running with one leg tied to a rock. We have to be able to find ways to be able to address these issues. Now, legislation is going to occur in many different areas. One, you're going to see legislation on the telehealth and allow for hopefully greater utilization of that. There's going to be legislation around remote patient monitoring. That'll be great, great to see more utilization of that. But we also need to see technological innovation that goes beyond what we currently do. Today, telehealth is about a video visit. Remote patient monitoring is about showcasing a series of different data over time. AI has to make that easier for us. It has to make this something that is more usable and much more predictive. When we get to that point, then it's a no-brainer for reimbursement around this. But there's no brainer for legislation, because then what we're talking about is ways that we can be much more effective, efficient, and something that will be more widely adopted. I think that's been one of the biggest challenges or questions when you start exposing these technologies. Is it actually really resulting in better care, or is it actually just resulting in more utilization? Hard to sometimes know and tease that out. But when we start thinking about how we can apply these to be able to start pulling in information related to one's environment and addressing those as part of these broader encounters, I think we have an opportunity to make a difference.
Absolutely. I agree 100%. The next question, do you think that engagement trust builds efforts for COVID-19 will create longstanding tools for communicating other health services such as cancer screening, vision screening, etc.?
Well, that's exactly what we were trying to do with the Vaccine Equity Consortium. It was something that we have seen absolutely does work, because the issue is not that they don't want to have this, sometimes there's resistance around the COVID vaccination, but there might be a general acceptance that the kids need to be vaccinated to get to school. Or perhaps, you know what, I don't mind getting my blood pressure or diabetes checked. I've never had that done. Oh my gosh, I didn't realize my blood pressure is so high. You mean I need to take medicines, or I should at least see a doctor about this? These are things that I had no idea about. Now, that's the type of information that can be presented back to individuals when they are in a receptive mode. Now, what we've also seen is that it doesn't work when you are trying to promote something and they're resistant to it up front. So a lot of people were surprised when they had these vans driving around these neighborhoods and say, we can get COVID vaccinations for anyone. If you've got questions or concerns about the vaccine, you're not going to go and stop the van and say, hey, I'd like to get the vaccine. The conversation has to occur first. Once that conversation occurs, then the very next step is, well, we can give you the vaccine and we can offer a whole series of other things, and it's right there. And that's why events tend to work really well. We've also seen another place that works really well is in shopping centers or other types of areas where people congregate. They're not there necessarily for the COVID shot or for health education. They're there for some kind of a family or other type of community event, but it's the perfect environment that allows you to be able to have an unpressured conversation. And then you have to make sure that it's easy for them to be able to get the next steps, whether it's the vaccinations, testing, screenings, or other types of programs enrollment. We found that one of the biggest issues and challenges, specifically in certain populations, has been concerned that this data might get used and potentially in a way that would expose them to immigration services. And that is something that has to be addressed up front. You have to talk about the concerns and you have to reassure people about how it will be used, who has access to it, and make sure that it's done by people who trust them. Once that conversation is had, then it has to be married with healthcare providers. So that's why I see this as a three-way combination: community, healthcare and public health, and technology.
Absolutely. So then the next question we have is, I love the opportunities to improve access and digital touch points across a continuum. What do you expect as trends across state or cross country border digital access for patients who travel, live in various locations, etc.? Kind of like what you were talking about earlier, owning your data.
That's right. And that's exactly where I was going to go with this. When we get to the point where individuals have access to their own health data, they become their own HIE. They become their own ability for them to go anywhere around the world and be able to share it. Now, there's two aspects to it. One is making sure that people can get access to that. And two, that other people can read that information. So interoperability is a critical piece. And that's why we talk about, why is interoperability important? Well, when you think about traveling, one of the most convenient things and most useful things is being able to go to an ATM be able to put your card in, which from a bank from another country in another language, and being able to pull out currency from that particular area. That's interoperability. That's the type of interoperability we need to have for healthcare. So people can be empowered to be able to go anywhere around the world, share information, and be able to make sure that that information is understood by whoever they are giving and granting access to. We're on that path. FHIR, Fast Healthcare Interoperability Resources, is the opportunity for us to do that. Now, admittedly so, we haven't gotten to the point where it's gotten huge adoption, but we're going to start seeing changes, and we're going to start seeing further development of the standards that allow us to be able to take greater advantage of the standard.
Thank you. Yeah, we've often talked about, why can the banking system figure it out, but healthcare can't, right? So,
That's right.
So the next question then we have is the potential of virtual reality to demonstrate conditions and surgical outcomes to the patient for better comprehension is phenomenal. Is this technology widely available? What are some other technical aspects an organization should consider for implementation?
So the good news is this function, everything I showed is things that could be done today in pretty much any place around the world. Now, there are, I'll say, basic infrastructure needs that need to be put in place. When we've worked with countries, third world countries or rural areas, some basic things like broadband access was not available. It doesn't have to be 5G or anything, but you have to have something. And so obviously with some caveats, we can see that there needs to be some things that we put in place. But if you want to make this scalable, beyond simply a one use or single use, these need to be thought of in terms of strategic plans as a platform play that allow for organizations to be able to take full advantage of a digital ecosystem. So I wouldn't really, I've shared many great use cases, but what underlies this is an organizational push to be able to think of data as being a central part of their strategy, and then how they manage that effectively across the care continuum. And what you'll find is that there's, I'll say, different levels of maturity. Oftentimes we think of data being within a particular system, maybe a device, but oftentimes it needs to be managed on a platform, which could be an on-prem system. But if you want to start talking about advanced AI, being able to do high performance computing, it's going to have to be on the cloud. And that's where a lot of the movement is being towards the big organizations that have the capabilities to start thinking about that. But you don't have to be big to be able to think big. A lot of smaller and medium-sized organizations also moving to the cloud, applying these technologies. And we're also seeing this in smaller hospitals and smaller health systems in places around the world. So it is something that anyone, anywhere can take advantage of. It just needs to be something that has to be done in collaboration with a broader strategy.
I know I was watching that. I was going, wow, that's where I want to go to have my surgery. I have to have knee surgery here in this next year. So I was like, okay, I need to choose to go to one of those really cool places.
Or you could go there and be supported by the world's class orthopedic surgeon who is 1,000 miles away, but providing guidance towards, instructing, here are the things that I would watch out for, and perhaps even participating during the surgery. But that's the type of transformation that we're going to see in how healthcare can be delivered. You don't always have to travel to the single site across the world that has the best surgeon, but you may be able to democratize that knowledge and help train a whole workforce of folks across the world.
That's awesome. I think we have time for one more question, Jordan. So go ahead and pull that last question up. And we have heard from providers who are concerned by a potential flood of patient-generated data. Can you speak to how this data can be ingested and enriched without being overwhelming to the health system?
Yeah, so two aspects to that. First off, from the provider perspective, the reason why I showed that and gave that example about Moneyball and the community-acquired pneumonia was because as a provider, I really don't want to get all the data streams in. I don't want to start hearing all the heart rate variables and all the blood pressure and the temperature spikes and things like that. What I want to know is, do I need to act now, or should somebody on my team be contacting them to see how they're doing? That is sort of the clinical question that I'm trying to answer. To do that, you have to synthesize all this information together. As opposed to looking at each single variable, you need to look at it holistically. And that's where AI can help. We can build those algorithms and then we can connect them to the appropriate triage system so that the individuals who can follow up could be just a phone call, simply saying, hey, I noticed that some things seem a little bit abnormal. Just want to see how you're doing, and perhaps maybe have a closer follow-up as opposed to routine follow-up. That's the type of support that can be helped me as a clinician. Now, what we also see is that organizations need to start thinking about how that data is managed. It really shouldn't be in the EMR as well, because put all that information in there means that somebody's looking at every single variable. What needs to be put in there are some of the key indices and the key actions and the coordinations and the steps that are provided. That's the clinical care that's being provided. All that other information needs to be managed separately, and that's an opportunity for healthcare organizations to start thinking about how they can look at pieces of information, some of which is EMR specific and some of which is not.
Right, and so like you said, that's where artificial intelligence can help, because we've had several conversations about what are we going to do with all this data. Your physician really can't wade through all of this data, so that was really interesting. How you showed that could actually be done through artificial intelligence. Dr. Rhew, I want to thank you so much. This has just been absolutely fascinating. We'd love to hear what you're doing, what Microsoft is doing, and thank you for giving us some time today. It's really exciting being in healthcare in today's environment.
Fantastic.
So,
Thank you, Doris.
thank you. So now we will be going into the next session, which will start in about 2 minutes. Before we leave to go to that session, I just want to share with all of you that at the end of the day, we're not going to have a wrap up. You will be going from session to session. So just want to thank you once again for participating with us today, for interacting with us, for being a part of our audience. At this point, we'll give you just a few minutes to leave this session and go into our next session, which is kind of an extension of what we've been talking about here with artificial intelligence and other things in futuristic healthcare. See you in the next session.